I'm now going to introduce Dr. Ciara Reynolds. Ciara works in the Institute of Public Health. She's a long and varied academic career, and she's well published in tobacco cessation, tobacco control, among a lot of other areas. Ciara works as a public health development officer in the Institute, and we commissioned the Institute of Public Health last year to conduct an analysis of our stop smoking services, to look at where we have services, where we have gaps, and what we might need to do to try and address that. As Paul said, we've got significant investment just in the last 6 months in terms of Sláintecare, and we look forward to receiving the recommendations from that report. It's not published yet, but Ciara is going to take us through some of the preliminary findings. It was a really comprehensive piece. It looked at, we surveyed our own staff in terms of our own stop smoking service. We consulted also with international colleagues in terms of what works in stop smoking services internationally, and also just looking at the map and where we have deprivation and where we have service and where the gaps might be. But Ciara will take you through that in just a moment. So thank you very much, and I'd like to welcome Ciara to the stage.
Thank you very much, Martina, for that introduction, and thank you for the invite to be here today. It's great to see you all. So as Martina said, my name's Ciara Reynolds, and I'm a Public Health Development Officer in the Institute of Public Health. And this is some preliminary findings of our report on how we can better focus stop smoking services on health inequalities in Ireland. So I'm going to start by taking you through a bit of background into the Institute. We were set up in 1998, and we're jointly funded by the Departments of Health in Ireland and Northern Ireland. The key priorities of the Institute are to promote health and well-being, to improve health equity and reduce health inequalities. And we work to achieve these through research and evidence review, policy analysis and evaluation, and partnership working. And that brings us on nicely to our review of stop smoking services within the HSE. As Martina said, this was commissioned for the Institute to conduct early last year, and it's being conducted currently by a subset of the policy team within the Institute. So this work really informs some of the actions within the HSE Tobacco Free Ireland programme plan, in particular identifying innovative ways to respond to and engage with the needs of different population groups, consider how we can better promote smoking cessation services, remove barriers to access and extend their reach, and to consider how the HSE Tobacco Free Ireland programme plan can maximise the impact across the population, with particular reference to health inequalities, people with mental health problems, and women who are pregnant. It also is highly relevant to a number of different actions within the Healthy Ireland Strategic Action Plan, specifically those related to health inequalities, smoking in disadvantaged communities, and review and evaluation of stop smoking policy. So before I get into what we did do, I just want to put some boundaries around the work that we completed. So this was a review of the HSE National Stop Smoking Services, although we are aware that there are a number of brilliant other stop smoking services and programmes available in Ireland. We didn't directly engage with service users or people who smoke in the general population, and we didn't analyse the impact of any public health awareness campaigns. Although we did engage with stop smoking services in other countries, we didn't do an evaluation of these services, and we didn't do a direct comparison of these services to our own. So in order to kind of focus and structure this report, we applied one of the most frequently used implementation frameworks in public health research called the RE-AIM framework. So this includes the domains of reach, effectiveness, adoption, implementation, and maintenance. However, we did have to adapt this framework slightly as it didn't fully fulfill all the objectives that we needed for this project. So we added an extra R for resource. And after we did this, we compiled the list of core questions that we wanted to answer within this project. To name but a few, these included what resources are invested in the stop smoking programme, how does the level of service compare to the level of need, and how effective are different components of the service at engaging with people who smoke. So we wanted to look, when we were answering these questions, we wanted to look at it with an equity lens. And what this means is we didn't want to just capture the amount of resources that are needed distributed across the population, but we also wanted to focus and look at what specific resources are needed for particular individuals or population groups in order to ensure that they have the resources that they need to promote fairer and better outcomes and to engage with the Stop Smoking service. So first, we had to decide on which equity groups we were going to look at. A number of factors were considered when choosing these groups, including which groups have higher smoking prevalence, which we heard from Dr. Kavanagh earlier. Also, which groups have lower quitting intentions and behaviours. Some of these groups, they don't have higher prevalence in smoking than the general population, but they may have higher or more immediate risks from smoking, such as pregnant women who smoke. For a number of these different equity dimensions, there was actually a gap in Irish data. So this is where we drew upon the experiences of the HSE Tobacco Free Ireland programme team in order to really bed down which different equity dimensions we wanted to look at in this research. So the review took on a number of different work streams. The main components were evidence review, stakeholder engagement, and quantitative data analysis. I'm going to talk you through some preliminary results of the top 3 that are on the slide. In the interest of time, I can't go through the preliminary results of all of these work streams, but just to touch on the other data that we did collect, we conducted focus groups with representatives from the mental health services, both inpatient services and the community. We analysed some existing data with a particular focus on equity groups, in particular the Healthy Ireland dataset. We did some resource analysis using Health Atlas Resource Analyzer and conducted both current and scenario-based resource analysis. And then last but not least, we conducted some service user data analysis that was collected on the Quit Manager data system. So I'm going to start with the staff survey. This survey was conducted in November last year, and 26 staff completed the survey. The majority of the respondents were female, aged 45 to 55 years, and all 26 reported that they were white Irish. Half of the respondents had worked in the HSE quit service for at least 2 years. So the first thing that we wanted to know was what the level of resources are currently within the service. So we listed all the different items and resources that should be available within the service, and then we asked the staff to rank these in order of not at all well-resourced or extremely well-resourced. What came out most frequently noted as not at all resourced were props and IT systems. And what came out on top for the extremely well-resourced items were quick kits and stop smoking advisor staff. We then wanted to know what resources are needed in order to enhance the service in the next 3 years. Again, we listed a number of different resources that are currently available, and we asked these to be ranked from 1 to 5 in order to least needed to most needed. What came out on top was clinical space, followed by training of stop smoking advisors, and then time given to actually deliver the stop smoking consultation. However, we're aware this is quite rigid, so we also provided a free text option for any resources that weren't captured within the list but are also needed to enhance the service. And the main results that we found were free nicotine replacement therapy for all, evening and weekend quit groups, out-of-hours supports, local advertising campaigns, and to prioritise clinical space within the enhanced community care and chronic disease management teams and hubs. So moving on to the reach domain of this staff survey. We asked the staff who were the least likely to attend stop smoking services. This was a free text option, and everyone could list at least 3 individuals or groups that they feel are least likely to attend. Now this wheel captures every group that was written down in these free text options. However, the bigger the segment, the more mentions the group got. So as you can see, people who are homeless, males, mental health service users, the traveller community, pregnant women, and those with multiple addictions were the most frequently mentioned groups that are the least likely to attend these services. But we didn't just want to know who are the least likely to attend, we also wanted to know how we are to reach these groups. And the staff came back with some brilliant suggestions. Home visits generally and to the travelling community, drop-in clinics in disadvantaged areas, training HSE stop smoking service staff on addressing other substance use, collaborating with peer-led traveller primary care programmes, community groups working with people in direct provision and mental health services. And then a number of people mentioned workplaces and having stop smoking services within different factories, manufacturing, agriculture and food processing were the main ones mentioned. So moving on then to the interviews that we conducted with some leaders of tobacco or stop smoking services nationally. We conducted these interviews with representatives from Finland, New Zealand, Ontario, Canada, and here in Ireland. We used a topic guide to structure these interviews, and they were all conducted on Zoom. They were all recorded, transcribed, and then analysed afterwards. So I want to bring you through some of the different initiatives and programmes that are available in these different countries on really reaching out to these specific equity groups. So starting with New Zealand, they have a very innovative way of reaching out to young women from lower socioeconomic groups. So they go out into the community. They offer things like facials, manicures, eyelash extensions, even childcare and free meals. They're very skilled. They build a great relationship with these women, and they might not mention it straight away. They might wait until much further down the line until they feel they have a really good rapport and relationship built with these women. I start to bring in different conversations on general health and stop smoking. So it's a really, really innovative programme. In New Zealand also, they found that the Maori women in particular, they have very high rates of smoking at their first presentation to a hospital in pregnancy at about 47%. So they actually started to roll out an initiatives, rewards-based programme in helping women to quit smoking, and they found this to be very, very, very successful, particularly in this group of women. Of course, I can't not mention here in Ireland, we have 3 dedicated midwifery-led stop smoking services, and this is very much due to be scaled up very soon. There's also a stop smoking service covering 6 of the 19 maternity units currently. And of course, we have pregnancy-specific stop smoking recommendations in the new national stop smoking guidelines that were published earlier this year. So moving on then to kind of the mental health domain in our equity groups. So in Ontario, Canada, they have a very kind of person-centred care. So they have a stop portal, and this screens anyone who attends the service for other mental health, substance use, or physical comorbidities. And when this is alerted into the portal, the person given the advice actually gets personalised guidance to give to the person. So they're not just tackling tobacco dependence, they're tackling more than that, or signposting to other services. As well, in Ontario, Canada, they work very closely with addiction agencies throughout the province. And these provide very intensive residential treatment or outpatient treatment to people who are reporting one or more addictions. Of course, here in Ireland, the HSE are working with Mental Health Ireland to develop clinical guidelines on smoking cessation, and they're also working on the tobacco-free campus and environments in mental health services. In New Zealand, some, not all, but some stop smoking providers do actually provide home visits to mental health service users. And these aren't equity groups per se, but they're another way in which New Zealand are enhancing their reach to different equity groups. So in Auckland in particular, stop smoking advisors are actually working with industries such as roading and construction in order to target the specific populations that have a higher smoking prevalence. Then again, in prisons in New Zealand, these are all now smoke-free. They have mentioned that there are limited resources. However, they do provide stop smoking support and medications to people who first enter the service. However, they do want to scale this up, and there are some trials ongoing, working closely with men's prisons and women's prisons, mostly around smoking cessation, education and promotion. It wasn't without its challenges, particularly in the administration of stop smoking medications, where people were starting to make nicotine packages with tea to try and get the most nicotine from the patch. I'm not sure if that works. However, they did quickly switch to lozenges, so this is just an example of different challenges that can be faced and overcome throughout the process. So next I'm going to talk through some of the barriers that have been experienced by the stop smoking services internationally. Again, one that's common to all is kind of the cost of NRT and stop smoking medication, and even if it is free, the cumbersome route in order to obtain this free medication. Lack of funding, again, was mentioned by most stop smoking services. And then low referral numbers and data really comes into this, because a lot of the stop smoking services said, we can't evidence that there is a need for more funding if we don't have the evidence for the demand. Another thing that was common to most was the lack of mental health stop smoking services. And then the lack of time for healthcare staff to deliver stop smoking advice alongside their clinical roles. COVID also brought along a number of challenges, such as digital poverty. It was much harder to reach these hard-to-reach groups when everything went online. And then incomplete data was to the fore during COVID. There was no way of really validating stop smoking attempts because carbon monoxide monitoring had to be ceased due to health and safety issues. So moving on, and I'm glad to see that there was far more facilitators than there were barriers that were mentioned by the stop smoking service staff. Again, free nicotine replacement therapy, stop smoking medication, easier routes to obtain these were to the fore, implementing carbon monoxide monitoring and a whole host of different data-related facilitators. In terms of kind of reach, person-centered holistic care, addressing more than one addiction at one time, implementing workplace initiatives, whole family approaches, home visits, and then financial incentives were mentioned, particularly to reach those groups like women who are pregnant and smoke, and lower socioeconomic groups. Another thing that was actually mentioned was sharing of knowledge and sharing of experiences, not only within your own service, but internationally. I think this was a really good way to demonstrate all the learning that can be gathered from just interacting with international partners. So next we asked some kind of blue sky thinking questions on what would you do with additional funding if you were given it. So New Zealand said that they would provide specific services to close gaps in inequality, and I suppose this will be addressed later on in the New Zealand presentation, so I won't go any further into that. They would also like to include an evaluation component and have that bedded down from the very beginning in the service planning stage. In terms of Ontario, Canada then, they wanted unlimited free nicotine replacement therapy to improve their data collection and reduce missing data, and also to increase reach, particularly among mental health service users and the youth. So moving on, Finland, again, very data-driven, more monitoring and evaluation of programs at both a local and national level. They also would like someone who is responsible for developing, monitoring and pushing the national cessation service systems. And then in Ireland, they had a number of different ways in which they would love to spend their funding. However, we did narrow this down to just 4. Honing in again on unlimited free nicotine replacement therapy and smoking cessation medications would be up there. If not that, then even just reduce cost to visit the GP. To diversify mass media campaigns and concentrate on certain groups like women who are pregnant and smoke or mental health service users, and also to have specific services available for these groups. So last but not least, I'm going to talk you through some of the preliminary findings of our rapid review on the barriers and facilitators for people who smoke of engaging with stop smoking services and how this varies by equity group. So we searched the database PubMed. We looked for quantitative and qualitative analysis or articles that were published prior to March 2021 when this review was conducted, and they must have been published in English. We didn't include intervention studies or any studies examining the barriers or facilitators to quit attempt, because this is very much based on engagement and accessing the service. So 140 papers were identified, 36 were included, and then we divided these out by different equity groups. The results I'm going to present today are just from the service user perspective, but we also did provide the results from the service provider perspective as well. So these are the papers that didn't have any particular focus on an equity group, so we call these kind of the general group. The barriers that are experienced here are work and time constraints, belief they should quit on their own, belief that nothing can help in quitting smoking, the cost of the service or NRT. They're unaware of services and or what they offer, and when they do engage with the service, they're afraid of feeling judged, nagged, blamed, or stigmatised. In terms of the facilitators then, more information on what the service are and what they offer, community locations, mobile stop smoking services, more flexibility, electronic and remote services, so very much related to access there. Moving on then to mental health, we found 4 papers that focused on mental health in particular. The barriers were literacy issues, use of stop smoking as a coping mechanism, a culture of smoking, and smoking being viewed as socially acceptable within kind of mental health services. And then a lack of determination, consistent motivation, self-belief, and self-esteem. In terms of the facilitators then, and just to say the facilitators in all of these papers were quite light touch, it very much did focus on the barriers. So we did struggle to put together the facilitator side of things. But in terms of mental health, the facilitators were the use of technology to aid literacy, professional stop smoking advice, easy to use and interesting information packs, and health awareness of different smoking related diseases. And I just wanted to highlight disability because the only one paper was found. It's very difficult to find any data on disability, to even find appropriate definitions for disability. So in terms of the barriers, there was lack of on-site cessation counselling, unable to obtain transportation to sessions, and sites not co-located in their primary clinics. So the facilitators then very much overcoming these access barriers and having on-site services, including the provision of stop smoking medications in one place. Then in terms of the ethnic and cultural background papers, we found 5. Some of the barriers included low quit intentions and lack of awareness of services, skepticism and treatment efficacy, thinking that the service was purely designed only for heavy smokers, inflexible or excessive working hours acting as a barrier to accessing the services during opening times, low confidence in the service, and then language barriers and cultural barriers as well. So the facilitators there, better knowledge in the services, better communication with primary care providers, and providing more culturally and linguistically appropriate smoking cessation resources and services. And last but not least, I'm going to present some of the findings from pregnancy, which captured the most amount of papers of all, 8 in total. The barriers here were mainly down to work and childcare commitments, lack of transport and geographical challenges, absence of resources that are tailored specifically to pregnancy, and then kind of mixed messages from healthcare staff on smoking and pregnancy. Also the belief that the programme just simply wouldn't be effective. So the facilitators then, home appointments, provision of childcare, prompt, easy access to support in convenient places, and financial incentives coming in there. So I'm aware that I'm nearly out of time, but I'm just going to go through some of the challenges and observations of conducting this project so far. So I won't even address the first youth. I think we've all been impacted by them and no one wants to hear about them anymore. So in terms of staff availability, we were working on a very small team in the institute. Then data availability was a huge one. We did have to draw from a number of different data sources. Even when we did, if we're looking at different equity groups, the sample sizes in national surveys get so small. And then when we did find any data on equity groups, it was very historic data, 10 years or more. So yeah, data availability and variability was the big one in this project. We did have strengths though. We did apply a very well-recognised and appropriate research framework. The data sources we did include, they were wide and plenty. I think you can see that there are consistent themes that are emerging from each one of them. We looked at a wide range of stakeholder views and data. So the next steps is to put together all the pieces of these puzzles and draft the recommendations. I'm sure a lot of you have recommendations in your head just from looking at the data I presented here today. And then we're hoping to finalise the report and, if we have time, get it externally peer reviewed before we submit it to the HSE Tobacco Free Ireland programme team. And before Elaine drags me off the stage, I would just like to thank the Tobacco Free Ireland programme team, in particular Ed, Martina, Paul, Aisling, Elaine and Katrina for all their support on this project. I'd also like to thank all the stakeholders who engaged with this piece of work. I know a lot of you are probably here today, so thank you for that. And also to my colleagues in the Institute of Public Health, in particular Director of Policy, Dr. Helen McAvoy, who's leading on this project. I think that's me done.
Thanks so much, Ciara. Lots to take in there. I think now it might be a good opportunity for us to stand and just move a little bit, because we've been listening for a long time.